Hello, we're going to continue with the diabetes. I was talking about the categories of diabetes, type 1, type 2, and gestational. And like you said, insulin is like a key that unlocks the cell so that glucose can enter and break down the carbohydrates, proteins, and fats. And the diagnosis can be based on a couple of things. The glycosylated hemoglobin, the A1C levels, which there's a permanent attachment of glucose to the hemoglobin molecules, and it reflects the average glucose exposure over the life of the red blood cell, which is approximately 120 days. Then you have the fasting plasma glucose levels that are usually you do more than one, and usually over 126 milligrams that you're looking for. And then your 2-hour plasma glucose using the oral glucose tolerance test with a 75-gram oral glucose load, or a random glucose level in a individual with symptoms, usually over 200 milligrams. And usually it has the classic symptoms of diabetes, and you usually take the glucose levels and check in regard to the time of the last meal, which would be important. Then why do we have type 1 diabetes? Well, pancreatic atrophy and loss of the beta cells, which is common in Caucasians over 12 years of age. The types of problems, it's autoimmune and usually multifactorial. Environmental and genetic factors are thought to contribute to the trigger of the cell-mediated destruction of the pancreatic beta cells. And antibodies that attack the islets cells, usually the B and T cells, and killer T cells are usually present in the cells. And macrophage destruction of the beta cells occurs with the loss of insulin production and an excess of glucagon. The non-immune causes are usually secondary to diseases such as pancreatitis or different idiopathic diabetes. There's a genetic susceptibility to type 1 diabetes, usually a first-degree relative, parent, or sibling with type 1, and a strong association with the histocompatibility complex. But like I said, it's a multifactorial disease with environmental factors. Viral infections can destroy the beta cells. H. pylori has been associated with it. Exposure to cow's milk proteins and relatively lack of vitamin D has also been implicated in type 1 diabetes. As you know, the symptoms is usually leads to insulin deficiency and hyperglycemia. 80 to 90% loss of the function of the insulin-secreting beta cells in the islets of Langerhans occur before hypoglycemic develops. You have the 3 Ps, the polydipsia, the polyuria, and the polyphagia, weight loss, fatigue, and of course the ketoacidosis, the high ketones. The treatment is a combination of insulin, meal planning, exercise, and self-monitoring of their blood sugars, and transplants. A lot of the kids, when I was at diabetic camp, more and more were getting pancreatic transplants and doing very well with it. The type 2 diabetes is more common than type 1. The risk factors, again, multifactorial: age, obesity, hypertension. Usually those over 30 are affected, physical inactivity, and a family history. Metabolic syndrome also, and it's described as central obesity, dyslipidemia, prehypertension, and elevated blood glucose levels. Basically, they have seen with type 2 diabetics amyloid deposits found on the islet cells, atrophy of the pancreas and liver, vascular sclerosis are usually present. You have resistance of the receptors on the cell, and decreased insulin secretion by the beta cells are major mechanisms that are responsible. And most beta cells, it's not all of them that are dysfunctional, but with the type 2, most of them are affected. You have the elevated serum fatty acids and lipid deposits inside the cell is responsible. Release of inflammatory cytokines from adipose tissue, reduced insulin-stimulated mitochondrial activity, obesity-associated insulin receptor resistance, insulin resistance in the tissues, especially in the liver, muscle, and adipose tissue, beta cell dysfunction where the cell mass of the beta cell is decreased, and inflammation and changes occur in the cell. In terms of glucagon, the pancreatic alpha cells are less responsive to glucose, and hyperglycemic results. And so there's many different mechanisms that can be involved in type 2 diabetes. Clinical manifestations, as you know, recurrent infections, visual changes, complications of neuropathy with paresthesias can result. And of course, it's a combination of exercise, diet, treatment of the obesity, or hypoglycemics, or bariatric surgery. There's other specific types of diabetes, genetic diseases, diseases of the pancreas, drug or chemical induced, and maturity onset diabetes of youth. Gestational diabetes is the one the other kind I want to zero in on, which is any degree of glucose intolerance with the onset or first degree recognition occurring during pregnancy. Frequently, you see it with African Americans, Hispanics, and Native Americans. And the recommendation is high-risk women who are found to have diabetes in their initial prenatal visit should receive a diagnosis of overt diabetes because they are at risk later on. 40 to 60% of women develop it 5 to 10 years later. Risk factors are obesity and a family history of it. And usually gestational diabetes develops, then type 2 diabetes later on in 5 to 10% of women. And like I said, many of them later on, 5 to 10 years later, if not immediately, develop diabetes type 2. And contributing factors for the gestational are insulin resistance and inadequate insulin secretion. Acute complications of diabetes are many. You've got the hypoglycemia, which is secondary to insulin therapy, can occur, and you've all experienced that at some time. Diabetic ketoacidosis, which is a pH imbalance with high ketones in the urine, secondary to decrease in insulin, where the cells are starved for energy, so they break down the fats. And then you've got the hyperosmolar hyperglycemic non-ketotic syndrome. It's a big mouthful. Serious condition in which hyperosmolarity and the hyperglycemia predominate. Usually you have alterations of sensorium and neurological symptoms occur in addition to the ones that you usually see with diabetes. Usually seizures, hemiparesis occurs. The ketones are usually minimal. The difference with the DKA is, with this, is that ketones are usually absent or minimal, where in the DKA they're very high. The blood sugar is enough to prevent the breakdown of fats. And the defect is lack of insulin, but with the water shifts to the extracellular fluid as a result of the hyperosmolality, and you've got glycosuria and dehydration. Usually an increase in BUN and creatinine with renal problems does occur. And there's an increased mortality up to 40% of people with this difficulty. So there's a loss of water as fluids as well as electrolyte abnormalities that occur with this. Other complications, Smojai effect, which is the rebound effect of when you give too much insulin and induces hypoglycemia. Usually in the wee morning hours, that is undetected. And usually Ketosis leads to the high blood sugar in the morning. So during the night they have the hypoglycemia, and the glycogen and the fats break down, and ketosis occurs, so they have the high blood sugar in the morning, so it goes undetected. And they usually have headaches on awakening, and they need less insulin, and most of the time the healthcare provider wants to increase the insulin dose. And then you've got the dawn effect, which is the hyperglycemia in the morning due to the release of growth hormone and cortisol. Usually during adolescent and young adulthood this occurs. That's due to usually the timing of the insulin dose, or they may need more insulin as a result. But usually it's the timing that is off, and they need more insulin, like you said. We talked about hypoglycemia, which is one of the complications, a low plasma glucose level. For newborns, this is less than 35 milligrams. For a child and adults, usually less than, we in our hospital say 70. It can be 45 to 70. Sometimes we call it insulin shock, insulin reaction, and we see the diaphoresis, tremors, tachycardia, and we give in our hospital, we give them the glucose gel, and if they're conscious, or the 15 grams of glucose at camp, the kids used to carry around 15 grams all the time, or you get the glucagon if they're unconscious for emergency situations. We mentioned the diabetes ketoacidosis, the absolute or relative deficiency of insulin, and an increase in counter-regulatory hormones. The most common, it occurs in type 1 diabetes, usually as a result of illness, trauma, surgery, myocardial infarction, and it's a result of fat mobilization that leads to an increase in ketones for the person. They've got the polyuria, but as a result of the ketones, cause small respirations and a fruity breath odor to their breath. And usually the administration of insulin to decrease the glucose, fluids, and electrolytes is important. We talked about the hyperosmolar hyperglycemic non-ketotic syndrome, which is a life-threatening emergency, usually precipitated by infections, medications, non-adherence to their diabetes treatment, or usually associated with type 2 diabetes. Some insulin deficiency, but it's not as profound a deficiency as DKA. And fluid deficiency is more marked as a result of the loss of fluids with the glycosuria. And elevated glucose levels are more marked than in DKA if you compare the two. Some of the same symptoms, the glucose, serum glucose is more often 600 milligrams. Absent or low ketones is the difference. And an insulin infusion combined with fluid replacement and electrolyte replacement is important. Somogyi effect, like I mentioned, most common in type 1 diabetes. Most of the time the person wants to give, the healthcare provider wants to give more insulin, but it's usually less of a dose, so it does have the rebound effect. The dawn phenomenon, in early morning glucose elevation without nocturnal hypoglycemia, related to the nocturnal growth hormone elevation, and you look at the dosage of insulin and recalibrate that as well. Many different chronic complications of diabetes: retinopathy, nephropathy, neuropathy, macrovascular can lead to coronary artery disease, stroke, and peripheral artery disease or infections. So I'll talk about the complications in the next segment.